Good evening. I would like to start by thanking everybody for joining us for what will be the final Lipedema World Alliance live stream for Lipedema Awareness Month. We are particularly delighted today to be joined again by two of our board members, Dr. Isabel Forner Cordero and Dr. Thomas Wright. Dr. Forner Cordero is going to talk to us about compression. She has got a wonderful background and a lot of really interesting things to say. So I will hand over to Isabel in a minute and ask her to introduce herself, talk a little bit about her topic, and then take us through her slides. We will then hand over to Dr. Thomas Wright, who will take us through his very interesting, relatively newly published thoughts on the benefits of lipedema reduction surgery, in particular, how they impact on range of movement, how they impact on reduced pain and overall quality of life improvements. So after we've heard from both presentations, we will then open the floor for a general Q&A. So please pop your questions in the chat as we're going through. I will then harvest questions for both of our presenters. And if you have any other feedback, any comments, please feel free to use as we go. Otherwise, I would like to ask you, Dr. Isabel Forner Cordero, to introduce yourself and to take over the screen with your slide share. And thank you very much.
Thank you, Kate, for this presentation. Okay. Oh, sorry. Let me try. My name is Isabel Forner Cordero. I'm a physical medicine and rehabilitation doctor. Sorry. Now are you seeing the full screen? Okay.
You're
okay,
perfect.
Sorry about.
No, you're fine. I forgot to record, so you're all good.
Yes. I'm a physical medicine and rehabilitation doctor working in the lymphedema unit in Hospital La Fe in Valencia, Spain, and I'm working with lymphedema and lipedema patients since 2000. So I have a lot of time seeing patients with lipedema. Yes. So my topic will be about what we know about compression in lipedema. So I have no disclosures to declare. And lipedema is a growing problem in Western countries. The knowledge and awareness among physicians are increasing. The research and publications are more and more frequent in our journals. And there's an increasing number of lymphedema specialists addressing lipedema. The social networks are giving lipedema more and more visibility, so the requests of the patients to be attended in lymphedema units are growing. Lipedema is a very frequent disease in women. It's provoking a bilateral enlargement of the lower limbs, a disproportion in the distribution of fat, with pain or discomfort and easy bruising. The feet are not swollen, and the patients often report a family history of lipedema. Other symptoms and signs are the loss of the concave spaces on the side of the Achilles tendon, and as the condition progresses, it's a prominent perimalleolar fat pads that are appearing. The cuffing of the ankles and the wrists, hypothermia of the skin, and the skin that is more elastic and compliant, so it can allow the skin to hold fluid. The involvement of the arms is reported in 30 to 80% of the patients. I think it's more frequent than that we knew before when we examined patients. And we are speaking a little about management. I like very much this figure from the Lipedema Foundations that illustrates very well that lipedema care is integral and has many different aims. We have to manage inflammation, to reduce fibrosis, to improve lymphatic flow, to take care about mental health, to promote overall health, and decrease adipose tissue. The aims of the management are to prevent obesity, to prevent the progression of the disease, to prevent or reduce the impact on musculoskeletal system and the impact on normal function. And the benefits that the patients report are a reduction in heaviness and pain, a better shape in their lower limbs, an improvement in weight control, mobility, and quality of life. So these are our tools. We have the congestive therapy, compression, the stress management and emotional support, the skincare, drugs, diet, and of course, liposuction, and the physical activity that is going to treat all of these endpoints. Why should we consider compression in lipedema? Is there edema in lipedema? Is there a lymphatic dysfunction? Can it reduce fat or inflammation? To answer the first question, there is an important controversy now in scientific community about the presence of edema in lipedema. Despite the first results from Hertz with high-resolution ultrasounds that could not visualize edema component, and they concluded that the confirmation of lipedema diagnosis was not possible with this tool. This other study from Allen and collaborators found with histochemistry that they found an excess of interstitial fluid in lipedema tissue may originate from dysfunctional blood vessels caused by probably a microangiopathy. So they concluded that lipedema may be an early form of lymphedema. There are other studies with lymphoscintigraphy in lipedema patients. These are the results from our study with 83 patients, and we found that these abnormalities were present in 47% of the lipedema patients, and there was no relationship between the stage of lipedema and the severity of lymphoscintigraphy findings. As you see in the first figure, this is patients with stage 2, stage 3 lipedema, and the lymphoscintigraphy was completely normal. And the second one is grade 1, the stage 1, and we found these abnormalities like popliteal nodes and an asymmetry in the tracer lymphoscintigraphy. So there is a lymphatic dysfunction in lipedema. More recent studies have found that there is an increased fibrosis and change in composition. There's a potential inflammatory route in lipedema that is via interstitial fluid accumulation resulting from microvascular dysfunction. And there's an accumulation of sodium in the interstitium and an adipose deposition that can cause the lymphatic bulk transport is compromised. There's an evidence of elevated platelet factor 4 that is found also in lymphatic dysfunction, and there is an increased level of VEGF type C in lipedema. And endothelial glycocalyx porosity could induce an excess fluid extravasation and inflammation. So there are still many questions regarding the pathophysiology of lipedema. So how to plan treatments to treat these pathophysiological mechanisms. This is a study from Tom Wright. This is a prospective randomized control study. And they found there was a control group with stockings and diet and self-MLD, and the other group was adding a pneumatic compression device. And they found that there was a significant decrease in leg circumference even after one session, and an improvement in pain, fatigue, and tiredness in both groups, suggesting that at minimum, women with lipedema should be prescribed compression garments. This other study from Serwinska found that there was a subjective reduction of the tendency of bruising and pain, and a tendency to reduce or maintain the volume of the legs. We perform a pilot study with very few patients. There was a washing period of 72 hours without any treatment. We prescribed and they put the compression garments, circular knitted, class 2 during 1 week, and one session of supervised exercise. And the mean of volume reduction was 313 milliliters per lower limb. So we found some results. The results from the different studies regarding compression are that it can reach a reduction or maintenance of the volume, a reduction of the subjective symptoms as pain, bruising, fatigue, and tightness, and at minimum, as Tom said, women with lipedema should be prescribed compression garments. But all this research has many limitations. There's no diagnosis test of certainty for lipedema. There are very few studies, very few randomized clinical trials. Many studies are performed with multimodal therapies, with very small samples. Some of them are surveys with subjective endpoints and self-diagnosis of lipedema, and compliance of the compression is not objectively measured. What about compression after liposuction? There is a recommendation, but we don't have any evidence about that. There are currently no guidelines to prescribe compression garments for lipedema related to the type of garment, fabric, or the level of pressure. No reported research is available concerning the type of hosiery and the level of compression. Therefore, the prescription is empiric and experience-based. In our experience, a phlebologist is more likely to prescribe round knitted, while a lymphologist will prescribe flat knitted garment. And what do the guideline states? There is a very recent guideline from Germany. The primary endpoint of all of them are that the aim of any therapy has to be the reduction of pain and symptoms. So this guideline states that the compression therapy should be used to reduce pain in the affected extremities, and it can be performed with medical compression stockings, with bandages, or self-adjusting devices, and in long-term, medical compression stockings are preferred. The patients should be informed that compression will not reduce adipose tissue, and the appropriate compression material should be individually chosen for comfort, for the effectiveness in reducing symptoms, and considering several segments for easier donning. So we can choose circular or flat knitting, and the lowest class that leads to enough reduction of the symptoms should always be preferred. Regarding the American standard of care published in 2021, they stated that compression needs vary depending on patient presentation, pain, and physical ability to don and doff. It has to provide comfort and a reduction of pain, and the selection of the compression style, fabric, and strength should be individualized. Multi-layer short stretch compression wraps or inelastic Velcro may be required to contain fluid, and we should always prefer the lower class that is good to decrease the pain. So a higher compression class does not equate to better results. And the Lipedema World Alliance has performed a position paper that is very coming very soon. Dr. Krupa told you some days ago about the statements about that, and but concerning compression, these are the statements. Lipedema pain and physical sensitivity have been reported to be reduced by compression, so it's important. Conservative management of lipedema should include lifestyle and nutritional optimization changes, compression therapy, and exercises to alleviate symptoms and improve quality of life. So what we do in our unit, we prescribed circular knitted class 2 pantyhose ready to wear in mild stages of lipedema to be worn daily and when the patient does sports. And since the feet are spared and full pantyhose are not easy to tolerate in warm countries like Spain, we prefer leggings, footless leggings. In moderate stages, you can prescribe circular knitted or flat knitted depending on the shape of the limbs to avoid these wrinkles. So if the patient has obesity, pronounced morphology or disproportion, fat lobes or deep tissue, and high differences in circumferences between calves and thighs, we will prescribe flat knitted custom-made garments. In advanced stages and in patients with osteoarthritis of the hands or in older ages, we prefer compression in 2 pieces, Bermuda and knee-length compression socks, because it's easier for the patients to don and off. And what we do with the arms, I don't have any answer for that, because I think that sleeves in the arms are difficult to tolerate. It can be a solution for some patients, but it's not easy to prescribe for extremities garments. The role of compression aims to reduce symptoms, the edema, to streamline the limb contours, and in case of pitting edema, we can prescribe the congestive therapy with multi-layer bandages. And as fat is not reducible by compressions, the garments are meant to avoid the accumulation of fluid in order to prevent swelling and possible progression to lymphatic insufficiency. What is the patient fears? This is a survey in patients with lipedema, and they reported that the top 3 reasons for wearing compression garments were the perception of being supported, the alleviation of lipedema pain, and an improvement in mobility, knowing that sometimes patients cannot tolerate compression garments, so their compliance is low. So for take-home message, just to emphasize that research is scarce and very necessary. Compression seems beneficial to reduce pain and subjective symptoms, not to reduce adipose tissue. It should be part of conservative management, and it's important to know that a higher compression class does not equate to better results. So thank you for your attention.
Thank you very much, Isabel, for your wonderful presentation. And I'm definitely getting the odd little message and so on. So I know we'll have some questions for you at the end. But before we do that, we'd like to hand over to you, Dr. Wright. So Tom, if you'd like to take us through your, as Isabel said, you've recently published some interesting thoughts. So we're very keen to hear your observations on lipedema reduction surgery. So please, could you introduce yourself and take us through your content? Thank you. Oh, I'm so sorry, you are muted still, Dr. Wright.
Sorry, had to find the button. Okay.
You're all
hi,
good.
Everybody. Yeah, so I am Dr. Thomas Wright, and I'm a phlebotomist or venous and lymphatic medicine specialist. I've been doing this for treating these disorders for 20 plus years, and I've been very interested in especially specifically lipedema, and been doing quite a bit of research as well as comprehensive treatment, both conservative and surgical treatment for my lipedema ladies. So I'm going to share some results of a recent publication, but first I want to thank Dr. Forner Cordero for her excellent presentation, and she also kind of set me up, so it's perfect because we're going to be talking about the these reduction surgery outcomes, but these are all built upon the conservative measures that she covered, and I'm going to go into more detail on that. And just so this is the paper, and I was just told this last month that this paper won the best plastic and reconstructive surgery global open, that journal's best paper of the year. So that's quite an honor, and I want to thank my co-authors, especially Dr. Herbst, who helped me with this tremendously. She did all the statistics, and I really couldn't have done this all without her help. So basically, we everybody has already noticed that women with lipedema can affect their gait and mobility, and so I looked for some criteria that the orthopedists use to measure these things, and so that we could better, so that we could show these changes that we see in the women, the reductions, and then hopefully the improvements from the surgery, by using things that the rest of the medicine world understands and appreciates. So this was the first paper from looking at lipedema reduction surgery. Now, a lot of people call this liposuction, but I really feel that liposuction it is defined as a cosmetic procedure, and this is really this is surgically different than just traditional cosmetic liposuction. At least in my hands, I take special precautions on the lymphatics. And also, the goal is to maximally debulk the tissue, not necessarily an aesthetic improvement, but actually to try and remove as much lipedema tissue as possible to improve their physical functions. So we documented knee joint improvements and gait improvements. This is the first to correlate patient-reported outcomes with physical measurements and show improvements in mobility that correlate with future disability and life expectancy. And I kind of already mentioned that this was something that we used these measures that were used in orthopedic literature. So here are those measures, and we see here, one of the things is just measuring the angle of the knee. The knee is a hinge joint and should be straight, and so what we commonly see is what a valgus knock-knee kind of deformity or at the knee. We also see just the bulk of the lipedema tissue inhibits the knee flexion, and so a normal knee would bend, would be 140 or 35 degrees of knee flexion, and in this lady, she's really just a little over 90 degrees. Similarly, we see an increased Q angle. So when we looked at these knee mechanical changes, we saw again the average lady with lipedema started with a reduced knee flexion, just right at about 120 degrees, and then improved to about 130, and I'm realizing I'm just and then similarly, we saw an improvement in the knee angulation with, on average, the valgus deformity. I'm just moving my, excuse me, I realized I was out of center. So we see that, or did that make it worse? We see that angulation of the improved from about 6 degrees to about 3 degrees, so about a 3-degree improvement. And the Q angle was not significantly affected. And this corresponded also with an improvement from their preoperative gait. Only 20% were normal, and postoperatively, and these were done like 6 weeks postoperatively, about 80% had a normal gait. Why is knee flexion so important? Because it's critical for just daily activities. You need a full 135 degrees of knee flexion to get in and out of a car or out of a bathtub, and you need about 100 to 100 and sometimes 110, depending on to descend and ascend knee stairs without being unsteady. So we saw a 16% improvement in the ability to go up and down stairs. Now that was we used this on this was based using the NIH PROMIS mobility outcome measures, and so these are a normalized, standardized rating questions for patients that so that we can look at these, and I'll go into that a little bit more, but we can look at these and compare it to a normal patient and where they fit in their overall mobility for each of these activities. So this is that overall mobility rating, and so normal would be 50%, and so so all the ladies, or almost all the ladies in the study, had below normal mobility before surgery, and you can see the average was about 36. Some did go to completely normal mobility by the PROMIS score, but the average, on average, they improved about 6 points. That's about double the improvement in mobility seen with a total knee replacement, which is pretty interesting, because I mean, we of course do knee replacements for people who our mobility is limited by arthritis of the knee, but this surgery, at least in these data, showed that it was that it improved the mobility even more than a knee replacement. So now walking speed improved 16%. Now, so Kickert and others have shown that this walking speed and being able to walk at a normal speed is associated with overall life expectancy, and decreased walking speed is associated with future disability. So those are important measures, and this is, so it's more than just obviously decreasing the pain, and we did see a decrease in pain, but it actually, these outcomes are correlated with future life expectancy. Similarly, a 27% improvement in ability to run short distance, and that was highly significant. A 12% ability to stand for an hour. So this is where I want to spend some time on this. All of these patients, as I started to, and Dr. Forner Cordero talked about the conservative treatments, and so they all had. She showed one of my publications, the results of that. And this is what we do for all our patients. All of them receive medical grade compression, and they need to be compliant with that before the surgery. We find that it not only it not only decreases pain as Dr. Cordero mentioned, but also it prepares the tissue for the surgery. We all prescribe review and go over an anti-inflammatory diet, and basically that involves avoiding highly processed food and focusing more on whole foods and especially avoiding refined carbs. Almost all of them received decongestive therapy. There was one or two that did not. And they were encouraged for home exercise programs, especially water and exercise, and to maintain or lose weight. And so Dr. Cordero shared some of the we did see a decrease in limb circumference, reduction of pain. Now, one or two of just from these conservative measures, and then we added the surgery on top of that. Now, the reductions didn't quite, the conservative therapy almost met criteria for improvement of quality of life on some measures, but didn't quite. And then when we added surgery to these conservative treatments, we saw the increase in mobility, the improvements in knee mechanics, and improvements in quality of life. And we did look at these mobility assessments with the conservatives, and we didn't see quite the change. We didn't see statistically significant changes like we did with the reduction surgery. So we saw from the surgery, we saw an additional 12% reduction in overall body pain. These are all the quality of life assessments using there's 8 domains that the RAND's short form 36 that we looked at, and on all of the domains, from physical function to role limitations, energy and fatigue, social functioning, and pain, all of those, and overall general health, all of those improved. So 12% overall improvement in overall health, an 11% ability to handle activities of daily living, a 13% increase in ability to complete tasks, and a 10% ability to complete tasks limited by emotional problems. So we also looked at the lobules. So those are extrusions that are classically seen in stage 3 lipedema. And so looking at these stage 3 lipedema patients, with the nearly 100% started with lobules in their thighs, and that post-operatively only a small percent had them. So knee sorry about that. With the knee lobules also improved. Arm lobules were also significantly reduced. And I'm going to show you some. So this is before and after, and you can see she's working on a lobule on that upper arm that we see very commonly in lipedema. and um, improvement in the arm, and here's that knee lobule before and after. So it could be argued that they experienced a regression of their lipedema stage, at least from a stage 3 to a stage 2. And so that is my slide presentation here for today. I thank you for your attention, and I'm gonna go back to my front slide of wishing everybody a happy World Lipedema Month as we're getting ready to end the month of June.
Thank you so much, both of you, for two such wonderful presentations. We're very lucky to have you both giving up so much of your time. And I think that it is, as you say, really interesting how both of your topics fit so well together. There are a lot of synergies which came through in your material, and I think are part of some of the really strong messaging for people about how to get those best outcomes from lipedema reduction surgery. And I know that's something that is always a challenge for everybody working with patients. How do we really focus in on quality of life? And I think you've both made some really good and useful comments that I'd like to pick up on about that. I would say, Dr. Wright, that it is the fact that you've published the first gait improvement paper is really striking, isn't it? Because if I think back to when I first met other women with lipedema, the recognition that I had from people walking past me and around me was visceral. My mum had lipedema, I inherited it from her, and I felt very at home physically with those other people because they had the same kind of pronation in their feet, that same kind of slightly rolling walk, almost a little bit more like a duck waddle, which is probably not the politest phrase to use. So maybe I should stick with pronating on the inside of the feet and therefore throwing out that alignment. But I think it's one of those things that people recognize on a very visceral level. It feels very familiar, and it's often not always talked about enough diagnostically. So I would like to probably start by talking a little bit about some of that with you, if we may.
Sure.
Tom. So having started by looking at how gait is improved by the surgery,
right,
do you see perhaps an increasing role for talking about gait diagnostically, and certainly when one refers to perhaps to disease severity, when you think about orthopedic implications?
Yeah, that's great. I mean, yes, I mean it's right in front of our faces, right? Because we see these gait abnormalities. I mean, that's one of the biggest. This mobility thing, I think, is one of the biggest challenges that women with lipedema face, and this is just real world. And I do think so. So what we commonly actually, and Dr. Forner Cordero with her background, can certainly talk about that too. But I'm just going to say that I commonly see a waddling gait, and that's just an imbalance from the bulk of the tissue to the pelvic muscles, and so that then and also the pronation also has that, and so the waddling and the what I call circumduction, where they have to put their, instead of going straight forward over each step, going straight forward, they pull the leg out. They have to swing the leg out a little bit to accommodate the bulk of the tissue in the inner thigh. So those I see, so frequently in my lipedema patients. Not all, but very many have that. And then the knee flexion also. So the restricted knee flexion then leads to decreased hamstring strength. And I mean, but I shouldn't be talking about this. This is Dr. Cordero's, this is her specialty. So she's going to have to chime in now.
Please do jump in, Dr. Forner Cordero. It will be wonderful to hear your thoughts on this, about how these body mechanics make a difference. So please.
Yes, we performed a study some years ago, a descriptive study with many patients with lipedema, and we were examining the orthopedic alterations, and I remember maybe 1/3 of them had valgus knees.
Mm-hmm.
So, and cavus feet were also more frequent than other kind of feet. We don't know really why, but in another study that we performed many years ago with a gait analysis in a gait platform, we saw that the ground reaction force was increased in patients with lymphedema and lipedema. In lymphedema, it was different because in unilateral lymphedema showed that the ground reaction force, that is the impact of the heel to the floor, that is measured with this device, was higher in the affected limb. So in lipedema, if it is associated with obesity, the ground reaction force is higher in both legs. So maybe it can increase osteoarthritis. That was also one of our endpoints. So osteoarthritis, we don't know if it's because inflammation and the weight, not always related to weight. So there's a topic that should be a topic for research, because we don't know really what is happening, but it's interesting, the relationship with osteoarthritis.
How did you know that that was one of my next questions, Dr. Forner Cordero?
I didn't know.
Because
I didn't know.
Reading my mind.
I would like to add, though, I mean, but just on a basic level, their mobility is limited. I mean, the more advanced the lipedema, the more their mobility is limited. So, yeah.
But my first observation was that patients with lipedema had more knee osteoarthritis than the other kind of patients. Right. So I included this on my study just to, and I performed X-rays to see that. I couldn't compare to normal population, but the prevalence of osteoarthritis was higher than the prevalence of knee osteoarthritis in normal population of these ages. And my sample was not made of patients with obesity. It was, there are some patients with obesity, 40%, but most of them were normal weight, but they had knee osteoarthritis. So there is a relationship, an association that we have to see in detail, more deeper.
Right. We also in this study we also found a much higher rate of arthritis and knee arthritis, especially in our lipedema ladies. I mean, nearly 50% had some. Yeah.
It's very high.
Yeah. I mean, so
normally. Was it related to obesity or not?
Well, I mean, we did say, I mean, it's hard to tease out because we did see it more in our higher stages, which are on average had a higher BMI. So, but even for like, I think it's like 20 for someone, if you look at compared to even when you looked at compared to their BMI, they had higher rates of arthritis than would be seen from just simple obesity. But we saw even more, higher rates of arthritis, and it is because of these mechanical stresses by the lipedema, just the bulk of the lipedema tissue. I mean, so it's I think it's a force multiplier, but obesity and lipedema together really put a lot of stress on the joints.
There are some really interesting kind of questions in that, aren't there, around what we see in lipedema diagnosis is so many people have been diagnosed. What we found in the Lipedema UK research we've done is that the average age of diagnosis was around 45 years old, and that's improving. That was in our first survey. So when we did our next I was going to say big survey, but that was the name of our first survey. When we did our next survey of several hundred people, the average age among that 250 respondents had dropped to an average age of around 40 to 45, around 40 as opposed to 45 plus. So it's moving in the right direction. And I would be interested in your thoughts, both of you, about the impact on wear and tear, because osteoarthritis, arguably, as you say, Tom, when you have that malalignment between the hip, the knee, and the ankle, and I actually think back to a very simple paper Dr. Stutz did, where he just drew some of that alignment. When you look at that and you say that foot pronation and the whole leg has been effectively pushed out, that wear and tear is going to be much greater on the inside of their knee joint, because you look at where the forces are going biomechanically. So I'm interested in whether either of you have seen a difference in the perhaps patients diagnosed at an earlier stage, or perhaps, Tom, people coming to you for liposuction who have lower stage, earlier age of lipedema at the point they're recognizing it and seeking treatment, and whether you then see a difference at the same, say, BMI as someone else in that wear and tear, if I didn't make that question too complicated.
No, I mean, that's a great question, but unfortunately, I can't tell you the data on that. I hope that this means that they will not develop arthritis in the knee, or if they do, it will be less. But I unfortunately I don't have data, that objective data I could get for you.
I promise we do. Sorry, Isabel, did you have any thoughts?
No, really no, because when I see patients in older ages, they didn't have a diagnosis, and now I'm seeing patients as you in UK with a diagnosis earlier, but they didn't have time to see the history of the biomechanical problems.
And I think it will be really interesting. I was struck that what you said, Dr. Wright, was about looking at the orthopedic, using the same outcome measures as are used for orthopedic knee replacement surgery. I wonder, we know that in other countries, like there's a very large study taking place in Germany at the moment around the funding of surgery for lipedema. Do you see a role for some of these orthopedic related measurements? Because at the moment, there isn't the evidence base, and we're not saying less patients will need a new knee, or actually will people fall less and have perhaps then a positive impact in not needing hip replacements and emergency surgeries.
Right.
I would be interested if you both might like to reflect and spin out a little bit around what role potentially could such biomechanical measurements have, and measurements about reduced orthopedic surgeries perhaps logically have when we think about the benefits of carrying out this surgery for the funders.
Isabel?
I think it's very controversial, because knee replacement in lipedema and in lymphedema has many risks too. the problem of damaging more lymphatics is real. We see many patients with edema after knee replacement without a diagnosis, a previous diagnosis of lymphatic insufficiency. So when I have a patient with a severe knee osteoarthritis, I don't know what to recommend her. It's controversial because if the patient cannot walk, it's bad for her health, bad for her weight, bad for her obesity, bad for her lymphedema or lipedema or lymphatic insufficiency. But with the knee replacement, we have a risk of damaging lymphatics and of infection, of failing of the prosthesis. So we really don't know what to recommend. There are no studies what we have to do. So I don't know if a measurement can help to this.
Well, so I wish I would have had more room in my paper, because I actually looked quite extensively into this. And you know, first of all, knee surgeries, again, like as Isabel has pointed out, that there's I mean, they can even make things worse in terms of the lymphatics. But so and they're very expensive. So treating the lipedema really offers a potential to reduce the need for knee surgeries and improve mobility, and also save a lot of money, because as you know, the average average knee surgery has, you know, a 4 or 5 day hospitalization. I mean, it's there, you know, it's $30,000 to $60,000 US. I don't know what that is in pounds or in euros, but it's quite a bit of money. And so you know, you're treating lipedema both conservatively and if needed surgically is a significant cost savings for if you because I can tell you quite a few patients who had knee pain, their knee pain improved. And there was also another recent study that showed that the presence of lipedema increases, you know, this was done by an orthopedist who said that, you know, having venous disease or lipedema or lymphedema increased the severity of knee pain and the arthritis and the progression of the arthritis. So I think we're slowly getting some information that this will help and save money in the long run.
Mm-hmm.
Yes, I certainly, I'm really interested in things like reducing falls with improving mobility, because we know the cost to that to the health services is very interesting. In the UK, for example, Tom, a knee replacement is probably around £16,000 if a person just goes and pays for one privately. I couldn't say what the cost is to health service off the top of my head, but yeah, it's a significant amount of money. I would like to just pick up a little bit, Tom, on what you're saying. You mentioned what you called kind of this sort of circumduction, and the way that the person's walking is effectively it's a more circular, thrown out gait. So what I'd like to do is pick up on the fact that both you and Isabel talked about how water exercise is beneficial. And what I'd like to ask you, Tom, is do you then think that movement and that way of walking means that, for example, perhaps exercising in water, aqua exercise as opposed to swimming, may be more beneficial because the sort of swimming motion, I mean, don't get me wrong, we encourage people to exercise in the water in whatever way works, but certainly something I think is an interesting topic is what's the most beneficial one and how do we adjust for buoyancy and other things. And that's a whole debate in itself, but I'd like to just sort of say, when we think about how lipedema affects gait and posture, would you like to start with how you see that then impacting exercise in water?
Well, of course. Well, I'm just going to take it the softballs, but because this is such an easy, fun question to answer. Is, obviously in the water, the weight and stress on the joints is taken away, and so it's going to both swimming and doing, aerobic walking in the water is going to be very beneficial. And I love this because this is something that Dr. Raprich and I have talked about is like, so not only, so there, you could be argued that they're both beneficial. Obviously, you get more upper body in the swimming, but in standing up in doing like the running in the water, you're probably getting more you have more water pressure, and so you're going to be stimulating more atrial natriuretic peptide release, which is a natural diuretic. And so I think I think they're both awesome, but I would think if I were just betting, I would say actually running in the water might even be better. But I don't know.
Yeah.
I agree completely. The impact on the joints is completely relieved. So it's very important when we are talking about patients with overweight or obesity or even osteoarthritis. It's important to avoid this impact biomechanically.
Yes. Yeah. Yeah. Speaking as a water fitness instructor, that it's something we certainly in the UK we've been really lucky to have a number of people at our congresses doing workouts in the pool with people, and it's something that I'm particularly passionate about. So I couldn't help but get that question in there. I would like Isabel to take us into a question that's a little bit detailed about something you said. You talked about how for patient comfort and then the ability to wear compression more often, because the feet are spared in lipedema, leggings were popular. I think it would be really helpful if you could talk to us, because we see people in sometimes leggings in your picture that went to the ankle. A number of companies now have capri leggings, which stop maybe mid-calf, depending on the height of a person. And then we also have people in more like what the Americans would call pantyhose garments, where the garment actually goes onto the foot. Would you maybe give people a little bit of your thoughts on how to decide which one of those lengths is perhaps more suitable for patients and what the advantages and options are?
Yes, the length of the leggings for me will depend on the type of lipedema. If you have a patient with type 3, that the adipose tissue is and will go until the ankle, the leggings should go until the ankle. But if you have a type 1 or a type 2 that is only until the knee, the thighs and the gluteus and so you can do a Bermuda or a or a capri, a shorter one. And I think it will depend only of the shape of the limbs and the symptoms. And I think they are quite well tolerated, the leggings. If the patient has some edema after when wearing a leggings, I would prefer pantyhose or both, and they will wear one day or another differently, so they can change and wear both.
I actually, so if they have it involving the ankle, I have always been told that to adequately control ankle swelling, it needs to go onto the foot. And so I will most of my recommendation actually is a pantyhose, open-toed pantyhose. And I don't really use much leggings. There are a few patients I have that have just limited to their thighs and buttocks, and then some of them I will, but I'm always concerned if I put compression that goes to the that stops at the thighs or stops at the top of the calf, that I'm creating a tourniquet and going to cause more swelling distally if I don't have that contained. That's my so I'm kind of old school in that you have to have the most compression at the far under where you have to at the under the most gravitational pressure, which is going to be at the foot and ankle. So
that's true, but if you check the patient and it's not swelling, it has not swelling with the leggings, you can use them. In my experience is easy to do like that.
Yeah.
Thank
Well,
you.
I'm certainly going to have to be a little more flexible on the leggings because I've always been telling ladies, oh no, you need the open-toed pantyhose. But maybe I will try this out, Isabel, and see if I can.
Just imagine to wear a closed shoes in summer.
Maybe I have not given
35 degrees.
Yeah.
So
I've not got given the fashion issues quite as much thought as you maybe.
But I think that's great feedback, Tom, because I think what Isabel said so well was the best garment is the garment that people can wear, and they can wear for a good amount of time in the day and a good amount of days in their week. The best garment is on, isn't it? And so I think it's interesting, and we're about on our time, but I would just like to ask Isabel, if I may, on that. What about something we have often encouraged people to do in the UK is if they struggle with pantyhose, wearing, for example, the legging and a sock, if they either have a doctor like Tom who recommends a foot coverage, because you can get an open-toed sock. And I just wonder, do you have those prescribed very much in Spain? What are your thoughts on those, both of you, but particularly?
Yes, I do it very often too. Especially in patients with stage 3 with big deformities, I always use two pieces. But most of my patients in the studies, are patients with stage 1 lipedema, because in these cases, I'm sure that they have lipedema and not other things added to lipedema. But in other kind of patients, I put always two pieces. Yes.
Thank you. Would you like to add anything to that, Tom? Or
No, I think this is no, it's great.
Perfect. We'll see Tom racing out to the compression sock shop, Isabel, as soon as we hang up the call. I could continue to ask you questions all night, because I think you both have some incredible synergies in the thinking that you have and the research that you've done, which fits so well together. And I must say, Isabel, I have definitely made a note to get that old study of yours where you put people on a gait platform. I will apologize, I haven't read it. I now must get it from you and I must read it. And I think this is definitely that combination around what's happening with lipedema posturally and in movement, because we see the pictures so posturally, we don't always look enough at movement. And I think having a greater conversation around lipedema and movement, and then linking that into compression and exercise, is super powerful. And it would be, I think, great for us as the Lipedema World Alliance to do a bit more of that. So I definitely want to continue the conversation with you both. But as I have already stolen 4 minutes more than the hour, I am going to let you both go for tonight. And I would just like to close by thanking you both so much for what has been such an amazing evening, and for closing out our July series of webinars. You've both been super great and super interesting, and I certainly feel very lucky to have you guys as part of our board in the Lipedema World Alliance, because there's so much that we can learn from you and so much we can all do together. So I will say that I know there will be more questions to come, I don't doubt. And if you have any other questions, anybody, please do feel free to add them. I know we had a question from someone just checking about what's distal. So the end of the limb, we talk about what's distal and proximal. So where Tom was talking about what the circulation's like and the fluid, if people have any in the ankle, because that's the distal part of their leg. And when Isabel was talking about the arms earlier, it would be the wrist when you're talking about the arm. So thank you very much for that last little question. And if anyone has anything else they would like to give us as feedback, they are welcome to pop it in our chat before it closes at the end of our stream, or to go onto our website, lipedemaworldalliance.com, and pop it through to us through our contact us. And I think both Isabel and Tom had their details in their presentations. You can watch the presentation back and share it with friends and colleagues. And we do have, we had 3 others, I think, over the course of this month. You can also see those in the YouTube where you're watching this. So please scoot around, click around, watch the other sessions, share feedback, comments and questions. And we look forward to getting together again to talk more with everybody. So thank you both so much. I can't thank you enough for a wonderful evening. And I wish you a happy last few days of the month. Ciao, ciao.
Thank you.
Okay.
Bye.